इसको got it करना है
meeting is held interested half protect
क्या करना है?
बस click करें
With all your due permission, sir, we are beginning with the session for today.
Okay.
Good evening, everyone. This is Batul from IGCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our eminent speaker for today's session. He is none other than a very renowned pulmonologist, Dr. Prashant Prakash, sir, Service Professor and Head at the Super Speciality Department of Pulmonary Medicine, SN Medical College, Agra. With the help of sir, we'll be taking a close look on today's topic, which is current trends in the management of interstitial lung disease. Before moving on to today's session, let us have a brief look on what the topic says. Interstitial lung disease is a group of lung disorders that involve inflammation and scarring of the lung tissue. The management of ILD has evolved significantly over the past few years, with new treatments and diagnostic tools becoming available, such as the use of high-resolution computed tomography, scans, antibiotic medications, etc. We'll be knowing more about the topic with sir's wonderful inputs and his knowledge. So now, without any further delay, I would like to welcome sir at our forum and would like to hand over the session to him for his precious talk to begin. Sir, over to you.
Thank you, ma'am. Thank you very much. And thank you to the august audience who have given their patience to listen to my topic. I hope I can do justice to it. I am Dr. Prashant Prakash. I am Professor and Head of Super Speciality Department of Pulmonary Medicine, Agra Medical College, Government Medical College, Agra. So, as briefly introduced, I would just like to deliver my talk on recent trends in the management of ILD. Right. So this is going to be the topic of my discourse. And slide. So interstitial lung diseases, as we all know, are a heterogeneous group of more than 150 disease entities that differ significantly with respect to prevention, therapy, and prognosis. The classification of interstitial lung diseases has processed through a variety of evolution, and the latest classification is as follows. Interstitial lung disease has been categorized into three now: unknown etiology, known etiology, and unclassified. So the known category, which we would like to take up first, is basically hypersensitivity pneumonitis, sarcoidosis, connective tissue ILD, drugs, radiation, infection, and occupation-induced ILD. Open back. Yeah. So this is the known category diseases of ILD. While the unknown category diseases of ILD include idiopathic pulmonary fibrosis, which is the most common type of unknown category of interstitial lung diseases and is also the most dreaded, non-specific interstitial pneumonia, cryptogenic organizing pneumonia and acute interstitial pneumonia, smoking-related ILDs, and lymphocytic interstitial pneumonia. Idiopathic pulmonary fibrosis is the one which is most rapidly associated with a fibrotic tendency, and the remaining can be fibrotic as well as non-fibrotic. Usually they are initially non-fibrotic. And of course, the end stage is always fibrosis. So because of the fibrotic part of these diseases, now another entity has come up, and that is PF-ILD, progressive fibrosis interstitial lung disease, which seems to be the end point of most of these conditions. Anyway, that is a separate topic in itself. So once we go to interstitial lung diseases, this classification of especially idiopathic interstitial pneumonias further evolved, and the American Thoracic Society and the European Respiratory Society in 2013, they divided the idiopathic interstitial pneumonias, underlying idiopathic interstitial pneumonias, which were basically the unknown category of ILDs, into major idiopathic interstitial pneumonias, rare idiopathic interstitial pneumonias, and unclassifiable cases. And the major idiopathic interstitial pneumonias were further grouped into chronic fibrosing, smoking-related, and acute/subacute idiopathic interstitial pneumonias. So this is the categorization of the idiopathic interstitial pneumonias, which is subcategorized into chronic fibrosing, smoking-related, and acute or subacute idiopathic interstitial pneumonia. Mind you, what we are right now talking is that we are talking of the unknown, so-called unknown category of interstitial lung disease, or which is better or more scientifically termed as idiopathic interstitial pneumonias. So chronic fibrosing interstitial pneumonias are subcategorized into idiopathic pulmonary fibrosis. It is the name which is most commonly known, and idiopathic non-specific interstitial pneumonia, or what is known as NSIP. Smoking-related idiopathic interstitial pneumonias are basically respiratory bronchiolitis interstitial lung disease and desquamative interstitial pneumonias, while the acute or subacute idiopathic interstitial pneumonias are those presenting acutely, and they include cryptogenic organizing pneumonia and acute interstitial pneumonia. The diagnostic strategy, how do you basically go about when you are managing ILD is, first of all, three things. That number one, try to find out its dynamic time course. Is it acute? Is it subacute? Or is it chronic? Second is, what is the cause? Is it known or the unknown category? Third is the context of disease at presentation. That is there presence of extrapulmonary or systemic disease manifestations or not? The management of ILD is also broadly divided into general management of common comorbidities, management of symptoms such as cough or dyspnea, pulmonary hypertension, and specific therapies. So this is the basically 4 categories of management of ILD. Number one, general management of common comorbidities. Second, management of symptoms such as cough, dyspnea. Third, pulmonary hypertension. And fourth, specific therapies. So coming to the first, and that is management of common comorbidities in ILD. The most common comorbidities encountered in ILD are gastroesophageal reflux disease, pulmonary hypertension, lung cancer, obstructive sleep apnea, venous thromboembolism. So these are the 5 categories of comorbidities commonly encountered in ILD. Gastroesophageal reflux disease, pulmonary hypertension, lung cancer, obstructive sleep apnea, and venous thromboembolism. What is the management of cough in ILD? There are many evolving therapies for cough in ILD, which include prednisolone. A short trial of oral prednisolone in distressing cough associated with idiopathic pulmonary fibrosis has been an appropriate consideration. Gabapentin has been used for intractable cough, and latest thalidomide is also being studied for use in the intractable or distressing cough associated with idiopathic pulmonary fibrosis. What strategies are involved in the use of management of dyspnea in ILD? Because ultimately most presentations of ILD are dyspnea. So basically in that we have pulmonary rehabilitation, supplemental oxygen, and a third experimental therapy being nebulized opioid therapy. Pulmonary rehabilitation is a much discussed modality. It is advocated in dyspneic patients with ILD. Pulmonary rehabilitation has no beneficial effects on survival. So if we are talking of beneficial effects on survival, then there are no beneficial effects on survival, and even in quality of life, even in the quality of life, when it comes to the quality of life, the quality of life is improved as long as the patient is in the pulmonary rehabilitation program. Then coming to supplemental oxygen, which is recommended in patients with documented resting hypoxemia and or exercise-induced hypoxemia and desaturation while sleeping. Long-term oxygen therapy, LTOT, is indicated for patients in ILD who have persistent resting hypoxemia. Nebulized opioid therapy is not beneficial to relieve dyspnea in all ILD patients and is more of a palliative care option. And presently, I would also say that it's more of a experimental modality. So, vaccination, the status of vaccination in interstitial lung disease. There was a consensus statement of Indian Chest Society and National College of Chest Physicians on management of ILDs, and this consensus has advocated vaccination for all patients with ILD, vaccination being both influenza and pneumococci. Management of pulmonary hypertension in ILD, the consensus statement of the same document of Indian Chest Society and National College of Chest Physicians on management of ILD endorses the guidelines for management of chronic pulmonary hypertension and specific therapy for patients with pulmonary hypertension, and mainly the treatment of underlying disease as the mainstay of therapy and supplemental oxygen in cases of hypoxemia. So basically specific therapy for patients with pulmonary hypertension, treatment of underlying disease, and supplemental oxygen in cases of hypoxemia. Molecules such as ambrisentan is contraindicated in patients with pulmonary hypertension related to idiopathic pulmonary fibrosis, and the therapeutic benefits of other pulmonary hypertension specific therapy in ILD related pulmonary hypertension really remains unknown. Then role of non-invasive ventilation and mechanical ventilation in ILD. Consideration of non-invasive ventilation is advocated as early as possible in patients who require high flow supplemental oxygen at rest, especially in patients who are having acute exacerbation ILD with respiratory failure, as it has been associated with better short-term outcomes. The consideration of mechanical ventilations in patients with acute exacerbation ILD with respiratory failure should be definitely taken with a pinch of salt and only after proper counseling, since the outcome is usually bad. Lung transplantation, actually, it is the only treatment option with clearly proven survival benefit in advanced ILD, especially idiopathic pulmonary fibrosis, while the post-transplant survival is variable in lung transplant programs. While the 5-year survival in most experienced lung transplant programs is about 70%, less experienced programs have lesser survival rates. So, coming then to the various modalities being used in the management of different types of ILD. Management of idiopathic interstitial pneumonias. First of all, the first and foremost is that you have to find out whether it is an idiopathic interstitial pneumonia. Because by the very diagnosis of idiopathic interstitial pneumonia, you have to exclude ILD due to drug or inhalational exposure or connective tissue disease ILD. And once you have done that, then you have to categorize the major idiopathic interstitial pneumonias, whether it is chronic fibrosing, smoking related, and acute or subacute idiopathic interstitial pneumonia. The commonly used drugs, the side effects and the management of side effects of commonly used drugs in ILD is outlined in this forthcoming table. So here are the entire list, the gamut of drugs which can be used in ILD. You have pirfenidone, you have nintedanib, you have N-acetylcysteine, you have prednisolone, right? These are the doses, these are the side effects, and these are how to manage these side effects. I would not like to go too much into the detail of basically each drug. That would take too much of time. What I am going to more emphasize is which drug to be used in which condition. Which drug to be used in which condition. So this chart depicts pirfenidone, nintedanib, N-acetylcysteine, prednisolone. Right. Going along with this list, we have then azathioprine, we have methotrexate, we have MMF, mycophenolate mofetil, we have cyclophosphamide. So the fifth, azathioprine, sixth, methotrexate, seventh, mycophenolate mofetil, then eighth, cyclophosphamide. These are the doses, these are the side effects, and how to manage the side effects. And coming to the last two is infliximab and rituximab. Infliximab and rituximab, these are the higher end drugs, and these are their doses, side effects, and how to manage the side effects. Now coming to exactly basically which drug to use when. Coming to chronic fibrosing idiopathic interstitial pneumonias, of which the most common and deadly is idiopathic pulmonary fibrosis. Until some time back, probably ILD was synonymous with idiopathic pulmonary fibrosis. So what is idiopathic pulmonary fibrosis? It's defined as a specific form of chronic, progressive, fibrosing interstitial pneumonia of unknown cause. Underline the word unknown cause, occurring primarily in older adults, 6th to 7th decades, limited to the lungs. There should be no extrapulmonary presentations and associated with the histopathological or radiological pattern of usual interstitial pneumonia defined. The definition of IPF requires the exclusion of other forms of interstitial pneumonia, including other idiopathic interstitial pneumonias and ILD associated with environmental exposure, medication, or systemic disease. IPF, as we discussed, is the most common entity amongst the IIPs, accounting for 50 to 60% of cases. Prognosis is usually worse compared with other IIPs, with a median survival time of barely 2 to 4 years. The diagnosis of IPF requires exclusion of other known causes of ILD, the presence of a UIP pattern on HRCT in patients not subjected to surgical lung biopsy, and specific combinations of HRCT and surgical lung biopsy in patients subjected to surgical lung biopsy. So now, once we are through with our diagnosis of idiopathic pulmonary fibrosis, how do you manage it? The consensus statement of Indian Chest Society and National College of Chest Physicians has outlined the following management protocols. First of all, pirfenidone and nintedanib are basically, and I emphasize this, basically they are the drugs for IPF, not other entities. All symptomatic IPF patients with the FVC of more than 50% should be initiated on pirfenidone. The patients on pirfenidone developing more than 10% subsequent decline in FVC in any 6 to 12 months period should be given a choice of continuation of therapy or switch to an alternative therapy depending on case-to-case basis. Similarly, the same thing holds true. All symptomatic IPF patients with FVC more than 50% predicted should be initiated on nintedanib. The patients on nintedanib developing more than 10% decline in FVC in any 6 to 12 months period should be given a choice of continuation of therapy or switch to an alternative therapy on case-to-case basis. Either pirfenidone or nintedanib may be chosen for patients with IPF based on patient preference and tolerability. So basically they are the same, except nintedanib is more expensive, right? Pirfenidone requires more frequent dosing. Pill burden is more. Halaki, now this thing has also been dealt with. You are having pirfenidone tablets in a dose of 600 milligram in one tablet also. Duration of treatment is lifelong. N-acetylcysteine is currently no more recommended for routine treatment of IPF and may be considered in certain subgroups on a case-to-case basis. More evidence is needed to recommend use of pirfenidone in combination with nintedanib or N-acetylcysteine, and dose of individual drugs to be used in such therapy in patients with IPF. So as of today, our statement is that either pirfenidone or nintedanib, not more both. Pirfenidone has been associated with slowing of the absolute decline in FVC, increases progression-free survival, and reduces mortality. Nintedanib also virtually the same thing, associated with reduction in decline in predicted FVC, acute exacerbation in risk of all cause, and respiratory related and on treatment mortality. Coming to idiopathic NSIP, non-specific interstitial pneumonia. What the typical presentation is breathlessness and cough of 6 to 7 months duration. It's presently predominantly in women, in never smokers, in sixth decade of life. Again, one must be very careful because the NSIP pattern occurs not only as an idiopathic condition, but also in a variety of settings, including connective tissue disease, ILD, hypersensitivity pneumonitis, drug toxicity, and in some patients with familial pulmonary fibrosis. Multidisciplinary diagnosis is especially important to establish the diagnosis of idiopathic NSIP. The consensus statement, what does it say? It doesn't mention anything about antifibrotics in this condition, and oral corticosteroids are the cornerstone of treatment of NSIP. Immunosuppressants such as cyclophosphamide may be used as an add-on therapy in patients not responsive to steroids. Corticosteroids improve the system score and lung functions with response more prominent in cellular NSIP, concomitant consolidation, seronegative ANA, shorter disease duration. In symptomatic patients, oral corticosteroids are the mainstay of therapy. So you can see that basically how much ILDs differ in the treatment and management. In chronic fibrosing IIPs, in the two diseases, there is so much of difference in the entire line of management. Then smoking-related IIPs, histological respiratory bronchiolitis is almost always present in current smokers and can be used as a physiological response to smoking. The only proven therapy for this type of ILD is smoking cessation. Only those who continue to be symptomatic in spite of smoking cessation should be considered for corticosteroid therapy. Desquamative interstitial pneumonia has been recognized in non-smokers also, perhaps reflecting extension of childhood DIP into adult life. 10-year survival remains approximately 70% with resistance to treatment in a significant minority. There is clinical response to smoking cessation alone or in combination with corticosteroid therapy, as well as some possible spontaneous resolution. Acute or subacute IIPs. So in this, we have cryptogenic organizing pneumonia, which typically presents with a subacute illness of relatively short duration, medially almost 3 months, with variable degrees of cough and dyspnea. Majority of patients recover completely with oral corticosteroids, but relapse is common. Cytotoxic drugs and steroid-sparing agents are used in addition to corticosteroid where there is slow response to steroids. A small group may progress to pulmonary fibrosis and 1/3 of patients can relapse. Factors that may predict poor outcome include the lack of lymphocytosis on BAL, predominant interstitial pattern of imaging, and histological features of scarring and remodeling of lung parenchyma. AIP is a distinct idiopathic interstitial pneumonia characterized by rapidly progressive hypoxemia, mortality of 50% or more, and no proven treatment. Survivors usually have a good prognosis, and coincidentally, it's almost very similar to ARDS. But some experience recurrences of chronic progressive interstitial lung disease. But what is needed to remember the differentiation of AIP versus ARDS is AIP is classically idiopathic. ARDS generally is associated with a known cause. Since there is no proven treatment, supportive care with oxygen supplementation and mechanical ventilation is indicated. Early corticosteroid therapy and combination therapy with IV cyclophosphamide and vincristine have been reported. So if you now, we have completed idiopathic interstitial pneumonia. See how much difference there is in 6 conditions. All the 6 conditions, the management is quite different in all of them. So now coming to the other major forms of ILD, coming to the known causes of ILD. Hypersensitivity pneumonitis, most common, they are farmer's lung, Bajraiger's or parrot keeper's lung, and pigeon breeder's lung. They appear to be more common in men and during middle age. Inhalation of organic particles is the commonest cause of hypersensitivity pneumonitis, but it can occur following inhalation of inorganic chemicals and occasionally ingestion of drugs. Traditionally, hypersensitive pneumonitis can be categorized as acute, subacute, or chronic. This is one condition which can present anyway, acute, subacute, or chronic. Acute HP presents 4 to 8 hours after often heavy exposure with fever, malaise, cough, dyspnea, and chest tightness. The symptoms remit over 24 to 48 hours in the absence of further exposure. The problematic hypersensitivity pneumonitis are the subacute and chronic forms, which usually occur with ongoing lower level exposure. Dyspnea, cough, and fatigue develop insidiously, and weight loss is a common feature. Patients with chronic HP are actually the worst. They typically do not give a history of acute symptoms, but present with diffuse pulmonary fibrosis, which must be distinguished from other conditions, including IPF and fibrotic NSI. The consensus statement of Indian Chest Society and NCCP, what does it state? Well, 3 drugs have been outlined as for the management of HP, and that is oral corticosteroids, azathioprine, and mycophenolate. Oral corticosteroids for 4 to 12 weeks are an appropriate treatment option for patients with acute or subacute hypersensitivity pneumonitis. Prolonged use of oral steroids, azathioprine, and mycophenolate should be based on clinical response and tolerance. And in patients with acute hypersensitivity pneumonitis, there is improvement in symptoms and lung functions with oral corticosteroids. However, this benefit is not sustained over long term. There is lack of evidence pertaining to duration and dose of corticosteroids for long-term therapy in HP, and prolonged use of corticosteroids and other immunosuppressants should be prescribed after weighing the benefit rate of individual response and side effects of these drugs. Ultimately, what is the management of hypersensitivity pneumonitis? Identifying the inciting antigen and its removal. So inability to identify the inciting antigen is associated with worse survival, and every effort should be made to identify the inciting antigen. And sometimes it is this very thing that is most difficult to find out. Coming to the third most important entity, that is connective tissue diseases associated ILD. CTD-ILD, as it is known, may be associated with pleuroparenchymal disease or sometimes interstitial tissue involvement of the lung. The ILD in CTD may be either an initial manifestation or may manifest after a long-standing autoimmune illness. The prevalence of CTD-ILD is highest in systemic sclerosis and least in SNP. Similarly, acute presentation of ILD is more common in SLE and polymyositis dermatomyositis. The management protocols of individual connective tissue lung diseases associated with ILD as per consensus statement of ICS and NCCP are as follows. First, RA-ILD, a very reasonably common entity. So here our first line of management is corticosteroids. They are used in the treatment of RA-ILD. And cyclophosphamide, mycophenolate mofetil, and rituximab may be used in the treatment of RA-ILD in case of no response to corticosteroids. Role of other drugs in RA patients who develop ILD. Methotrexate should be discontinued in patients of RA diagnosed with ILD. Very important point. Methotrexate should be discontinued in patients of RA diagnosed with ILD. Leflunomide can be continued in patients diagnosed with RA-ILD, and other anti-tumor necrosis factor agents may be used cautiously. Scleroderma-associated ILD. Low-dose steroids may be continued in the treatment of scleroderma-associated ILD. High-dose steroids should be avoided. It has associated with the risk of renal crisis. Immunosuppression and secondary infection are dreaded complications of these drugs. Treatment in scleroderma ILD may be initiated in cases with progressive disease with either cyclophosphamide or mycophenolate mofetil. Mycophenolate mofetil has better tolerability and lesser side effects, though it's more expensive. Azathioprine is an alternate drug for maintenance therapy in scleroderma ILD. So either we have cyclophosphamide or mycophenolate mofetil. It just means mycophenolate mofetil is better tolerated, lesser side effects. And the third alternative is we have azathioprine. Rituximab should be considered in patients with refractory scleroderma. It should be administered at tertiary care level. Nintedanib, an antifibrotic drug, has been shown to reduce the annual decline in lung functions associated with scleroderma ILD. However, there was no advantage on the other manifestations of scleroderma. Sjogren syndrome. The treatment of Sjogren syndrome and ILD remains empiric since no controlled studies have been performed. In symptomatic patients with Sjogren syndrome and ILD and functional deterioration, the standard treatment is oral prednisolone in the diet dosage of 1 milligram per kg per day with subsequent tapering, continued for at least 6 months. But the patients who do not improve with systemic glucocorticoids should receive azathioprine, cyclophosphamide, and cyclosporine. Dermatomyositis and polymyositis. Treatment of ILD in patients with myositis almost always requires glucocorticoids, regardless of whether pulmonary or muscle disease is the predominant feature of patient's illness. No controlled trials of glucocorticoids have been undertaken. About 50% of myositis patients with ILD do not respond to steroids. Since ILD is a fatal disease in this condition, a second agent is added right from the beginning of therapy in patients with dermatomyositis or polymyositis complicated by ILD. Options for these second agents include azathioprine and methotrexate. Azathioprine is preferred because of its variable side effect profile. In patients with moderate to severe ILD, we can even go for cyclophosphamide. In patients with inexorable disease, rituximab or IV immunoglobulin are the most commonly used treatment options. The commonly employed drugs for CTD-related pulmonary diseases are listed in this table. So, corticosteroids, cyclophosphamide, methotrexate, and azathioprine and biological agents are the main drugs used for CTD-related lung diseases. RAILD usually responds to corticosteroids and methotrexate. Corticosteroids are not useful in scleroderma-related lung diseases, and cyclophosphamide is the drug of choice. Acute lupus pneumonitis responds to corticosteroids. Collagen vascular disease-related OP and CP has good prognosis and responds to corticosteroids. And collagen vascular disease, OP and CP has good prognosis, response to corticosteroids. Polymyositis, dermatomyositis related lung disease is fatal. Corticosteroids and cyclophosphamide should be used almost from the beginning. Then the last entity which I would like to take is sarcoidosis. Consensus statement, what does it say? Corticosteroids improve dyspnea score, lung functions, and radiology in sarcoidosis. Corticosteroids have no significant benefit in the asymptomatic stage 0 or 1 sarcoidosis. Moreover, the effects last as long as they are used. There is no long-term benefits in terms of lung function. Immunosuppression is a concerning feature for corticosteroids. What are the other agents used in sarcoidosis? Methotrexate, azathioprine, leflunomide, hydroxychloroquine. They may be tried in patients not responding to oral steroids or with associated steroid toxicity. Infliximab may be tried after carefully weighing the risk-benefit ratio in patients with refractory pulmonary sarcoidosis. So, management protocols in sarcoidosis: observe patient without pharmacological intervention in stage 0 and 1. Treat patients in symptomatic stage 1 and all stage 2, 3, 4 patients with oral corticosteroids. And that is, in a nutshell, a very brief summary for the treatment of sarcoidosis. So in this lecture, basically, I have tried to cover idiopathic interstitial pneumonias as briefly as possible. I've tried to cover hypersensitivity pneumonitis. I've tried to cover connective tissue disease associated ILD, and I have tried to cover sarcoidosis, which make up the lion's share of basically ILDs. The other being basically radiation-induced ILDs, drug-induced ILDs, occupational lung diseases. We practically know that what is the kind of management. And another point, once again, which I would like to emphasize is that basically rampant use of antifibrotics is not really the answer for managing a case of ILD. We need to be sure about the diagnosis of ILD, and then alone should we proceed. Thank you.
Thank you so much, sir. Thank you for such wonderful inputs upon the topic that you have shared today with us on this World Tobacco Day that we're celebrating today. So thank you so much for the awareness and for such a wonderful topic. We have received few questions, sir. I would like to put it across to you with all your due permission.
Absolutely.
Yeah. So the first question is, sir, what are the differences between idiopathic pulmonary fibrosis and non-specific interstitial pneumonia?
Yeah, so this is a very good question. Idiopathic pulmonary fibrosis and non-specific interstitial pneumonia are basically differentiated by the histological pattern and then the coexisting CT pattern also. For example, the idiopathic interstitial pneumonia is basically characterized on CT at least by basically lower zone predominance, subpleural presence, and absolute almost lack of ground glassing and consolidation, while non-specific interstitial pneumonias have that. Now, the second important thing is that non-specific interstitial pneumonia has in fact now been considered almost like a waste basket. What you cannot diagnose, what you do not have as a specific histological pattern like IPF, IPF has a very specific histological pattern. RBILD, acute interstitial pneumonia, they have a very specific histological pattern. What could not be categorized is non-specific interstitial pneumonia. And what makes hell of a difference is in the line of management. While antifibrotics are the cornerstone of management of IPF, it is corticosteroids which are hopefully, that is in most of the cases, the cornerstone of management of NSIP. And what is also another important thing which I want to emphasize is that IPF and NSIP both are present in hypersensitivity pneumonitis also and connective tissue ILD. Hence, the absolute need that any secondary causes of IPF and NSIP should be removed before you are actually categorizing them as IPF or NSIP.
Thank you so much, sir. Thank you for answering this question in such an elaborative manner and for making our viewers understand it better. Thank you so much for that. We'll move to the next question that we have received. And the question is, how is exercise capacity affected in the interstitial lung disease?
What? Yes.
Yeah, the question is, how is exercise capacity affected in interstitial lung disease?
Well, exercise capacity is bound to be affected because dyspnea is the cardinal manifestation of interstitial lung disease. See, first of all, here again, I would like to emphasize that interstitial lung disease is now considered to be a misnomer. Basically, in interstitial lung disease, it is not a disease of the interstitium. It is also a disease of the alveoli, and hence the better term today is what we use as diffuse parenchymal lung disease. Initially, what was thought was that basically this interstitial lung disease is a disease of the interstitium, is no more valid. It is basically involving the alveoli also. And in many cases, such as, for example, RBILD, it is involving the respiratory bronchioles also. So when the patient is basically cardinally manifesting as dyspnea, so exercise-induced dyspnea is a very important feature of determining the morbidity of ILD.
Thank you so much, sir, for answering this question. We'll move to the next question. And the question is, in patients with interstitial lung disease, what would you suggest? Which mode of ventilation is better, volume versus pressure mode?
Well, now, if you want to basically go for this question, I would first of all say that any form of invasive ventilation is a very bad mode of therapy for interstitial lung disease. Whether it is, leave aside infective exacerbations of interstitial lung disease, if a patient is going all the way to mechanical ventilation, it is really a bad manifestation, and the prognosis should be taken with a pinch of salt. But now, coming to the point of the question, see, in volume controlled and pressure controlled, while in volume controlled you fix the volume, the pressure may go to any extent. In pressure controlled ventilation, what you do is you fix the pressure. You give a certain beep, you give a certain pressure support, and the tidal volume is achieved by the patient. So when you are talking about ILD, that is basically a stiff and compliant lung, we should be more worried about the pressure rather than the tidal volume per se. And if you strictly ask me, I would go for a pressure controlled ventilation, which is much more safer in ILDs.
Thank you so much, sir. Thank you for answering this question. We'll move to the next and the last question for today's session. And the question is, what is the role of azathioprine and steroid-resistant ILD?
Well, azathioprine, I have already stated, is immunosuppressant and has got a good role in many ILDs. Not a very good role in the most severe form of ILD, idiopathic pulmonary fibrosis. I wouldn't be using azathioprine in that. But as my lecture has also stated, that in various other forms like NSIP and hypersensitivity pneumonitis, those patients in which steroids are not working, right? We are not getting such a better efficacy by steroids. It is a good entity. And second of all, it is also a good entity in patients where there seems to be an absolute contraindication of steroids. So azathioprine is a reasonably good drug. It is an immunosuppressant, and of course, it does carry all the disadvantages of immunosuppression.
Thank you so much, sir. Thank you for answering all the questions and for emphasizing upon the topic so much with such an elaborative manner and sharing such wonderful inputs with all our viewers who are present here with us today. We hope that the insights shared by you and the information shared by you upon this topic will definitely help them in their daily clinical practices. So thank you so much for that. And at the outset, I would also like to thank all the viewers who have taken out their valuable time and who have been here with us throughout the session until right till now. And I would also like to thank you, sir, for taking out your valuable time and for being here at our platform. So thank you so much, sir. With this and with all your last comments, sir, we can conclude the session here for today.
Thank you. Thank you very much.